Welcome back to our session, our final pharmacotherapy session. Again, I'm Vincent Dagenet-Beaulieu. I'm a pharmacist. I'm a clinical pharmacist working in both palliative care and mental health. So, hence our previous talk about depression and other psychotropic drug. And right now, we will have our third session about pharmacotherapy. And I'm very delighted to have Dr. McPherson, who will be able to present. So here she is. You can see that she's zooming in. Hi, Dr. McPherson. And
Hello.
we see you very well. So let's hope everything goes well. And so she is. I'm not sure she needs introduction, but I'll do it anyway. So she is a professor and vice chair in the Department of Pharmacy Practice and Science at the University of Maryland School of Pharmacy in Baltimore. So she serves as a consultant pharmacist for both local and national hospice and palliative care programs, and designed the critical thinking process for appropriate use drug use in end-of-life patients. So she serves on both boards of Hospice Network of Maryland and the Maryland Pain Initiative. So she's also a fellow of the American Pharmacy Association and the American Society of Health System Pharmacists. Dr. McPherson is board certified in pharmacotherapy, certified diabetes educator, certified pain educator. So she has many different hours. I cannot list them all, but and she has written 4 books, many chapters, peer-reviewed articles on pain management, palliative care, and other topics. So without further ado, here we go for Dr. McPherson.
Thank you very much. So the title of my presentation is Quick Medication Tips, New Drugs, Updates on Pain and Symptom Management, kind of the kitchen sink approach. And as you heard, my name is Lynn McPherson. I'm faculty at the University of Maryland in Baltimore, and I'm the program director of our awesome online graduate studies in palliative care, which include graduate certificates, a Master of Science, and the first PhD in palliative care in the United States. All righty. So nothing to declare, and these are my learning objectives. We're going to talk a little bit about opioid conversion calculations, what's new. We're going to talk about some tools to try to achieve goal concordant prescribing and deprescribing, and then look at some contemporary issues. We'll talk about secretagogues and the management of treatment-resistant constipation, nausea, and so forth and so on. All righty, so first we're going to talk about opioid conversion calculation. So I'm very interested in this, and I actually, as you heard, wrote a book on it because I think the reason I wrote it is I thought, boy, somebody should write a book on this because we need more guidance. So why would we need to change from one opioid to another? Well, some obvious reasons are a lack of therapeutic response with the current opioid. Someone develops adverse effects, and you hope they'll have less adverse effects on a different opioid. Change in patient status, like one of our home hospice patients needing to go inpatient because of a pain crisis, or a patient who was in the hospital or an inpatient unit on an IV and now they want to come home on oral, or maybe they can't swallow and want to go to transdermal fentanyl or buprenorphine. Some other considerations, the availability of opioids and their formulations, formulary issues. For example, branded products are very expensive. So if someone was admitted to our hospice and one of the branded, very expensive opioids, when it was time to renew that prescription, we may want to go to a generic long-acting morphine or methadone, which are much more cost-effective. Or because patients and families have healthcare beliefs that would guide us to doing a switch. Alrighty, some terminology I think that we need to make sure we have. Opioid responsiveness is the degree of analgesia achieved as the dose is titrated to an endpoint defined by either intolerable side effects or the occurrence of acceptable analgesia. So it's the sweet spot where you've gotten the most maximum therapeutic effectiveness out of the opioid. Potency is the intensity of the analgesic effect of a given dose. And this depends on access to the opioid receptor and binding affinity. So when we talk about equipotent doses, those should be equianalgesic, which comes to this whole practice of equianalgesic opioid dosing. Another term is bioavailability, which is the rate and extent to which the active ingredient or active moiety is absorbed from a drug product and becomes available at the site of action. And I've given you some of the common ones here. Morphine, obviously, is only about 30 to 40% bioavailable. So what does this mean? It means if you swallow 10 milligrams of oral morphine, it goes down in your gut. The first place it goes is into your hepatic circulation. And because of this first pass effect through the liver metabolizes, as you can see, 60 to 70% of that drug. So 3 or 4 milligrams will make it out of the liver into the systemic circulation so it can cross the blood-brain barrier and bind to your opioid receptors. Hydromorphone is about 50%, but you can see there's a huge range. Oxycodone is 80%. Oxymorphone is pretty pathetic at 10%. Alrighty, so this is the chart that I use. It's in the second edition of my book. And some people argued, should we even have a chart anymore? Do we have data to really support all of these calculations? Some are better than others, I will say that. I do still favor using a chart. I think it's easier for people. So the way this works is everything in the parenteral column is pretty much equivalent to each other. Everything in the oral column is pretty much equivalent to each other. And if you go across a row, like 10 milligrams of parenteral morphine, as I just shared with you, is about 25 milligrams of oral. And you can even cross columns and lines. So for example, 2 milligrams of IV hydromorphone would be about 25 milligrams of oral morphine. So I find this very useful. So even though my chart is pretty awesome, all of the charts have problems. And I will say, if you work at an institution where you have their own chart, just go with that if that's working for you. I don't want to, try to sway you away from what you're already using. But we do have to consider the sources of the equianalgesic data. For example, when this first chart first came out, it was listed that 10 milligrams of IV morphine was 60 milligrams of oral morphine, but that was based on single dose studies. Like, let's say we were all together in a room right now and I gave you some painful insult and it took 10 milligrams of IV morphine to relieve your pain, and we all came back next Friday and we gave you the same painful insult to treat that same pain with an oral morphine, it would be 60 milligrams, and that is correct. But we rapidly figured out that the contribution of the morphine 6-glucuronide metabolite, which is active, really means with chronic opioid dose, chronic morphine dosing, it's really only about 2.5 or 3 to 1, not 6 to 1. So you have to consider where the studies, are they retrospective? Are they prospective? Are they single dose studies? Are they steady state? So a lot to consider. And none of the charts, even though mine I think is awesome, none of them consider patient specific variables. Is the patient young? Are they old? Are they skinny? Are they fluffy? What's their organ function? And then we always have to ask ourselves, are these bidirectional? So if 10 of this is 20 of this, is 20 of this still 10 of that? So there is a difference between the first edition of my book is that I use the chart on the left, as you can see, and that's probably the chart that most people are still using in practice today. 10 milligrams of parenteral morphine is 30 of oral, and 1.5 milligrams of parenteral hydromorphone is 30 of oral morphine. So that's a 20 to 1 ratio, and you're either, according to my opinion, is you're either underdosing or overdosing, depending on which way you're going. So as you can see, the chart on the right, I made some changes. So why did I make these changes? Most of them are predicated by a really excellent study looking at converting off of IV hydromorphone, and I'm going to show you that now. Well, before I do that, the conversion of parenteral to oral morphine. Most charts, like if you look at this one right here, the old chart, most charts in existence say 1.5 milligrams of parenteral morphine is 7.5 oral. So that's a 5-fold difference. And we know the bioavailability of oral morphine is about 50%. So again, depending on which way you're going, you're either overdosing or underdosing if you use that old data, which really is not even evidence-based medicine. So do we need to evaluate going the other way from oral to parenteral? No, because when we look at oral versus parenteral of any medication, the only thing that really determines that is the bioavailability. And certainly pharmacogenetics may have a bit of an influence. And we know that clinical experience in large patient populations, we see the average conversion is 1 to 2.5. Every 1 milligram IV is 2.5 milligrams oral, which is why on my chart, I have 2 milligrams parenteral is 5 milligrams oral. Now, this is the study that changed the whole darn chart, in my opinion. This study was done by Dr. Akila Reddy, who is a palliative care physician at MD Anderson in Houston, Texas. And she looked at, I think, like 400 patients who had been stabilized on IV hydromorphone. And then she looked at, they all had cancer. They were converted to either oral hydromorphone, oral morphine, or oral oxycodone. And as you can see here, 1 milligram of IV hydromorphone, if it put less than 30 a day, turned out to be 2.5 milligrams, which I just shared with you. If they're on greater than 30 milligrams, it was a little bit lower, 2.1. people on IV hydromorphone going to oral morphine, it was about 11.5 or 12. And then if there were a much larger dose of hydromorphone, it was a little bit less. And then IV hydromorphone to oxycodone, it's a 1:8 ratio. So as you can see, building on this data, by me switching in my table on the bottom left here, 2 milligrams of hydromorphone is 25 of oral. That's a 1 to 12.5 ratio, which is pretty close to what Dr. Reddy found. And actually, when I was debating this whole equianalgesic thing with someone, so I contacted my good friend Dr. Reddy, and I said, look, you got to do me a solid here. I need you to pull some charts and look at the ratio going back the other way. So looking at oral morphine and going to IV hydromorphone. And I said, I want to be able to say that this is bidirectional data. And she did. She pulled 25 charts, and it was exactly 12.5 of oral morphine was 1 milligram of IV hydromorphone. So hopefully she'll take that on as her next project and do a more systematic study of going back from oral morphine to IV hydromorphone. So this study is getting to, is it bidirectional? IV hydromorphone to oral morphine, is it equal to oral morphine to IV hydromorphone? So this is only one study by Lawler, which looked at converting from hydromorphone to morphine, both by sub-Q, and they looked at oral to oral hydromorphone and morphine. So going from morphine to hydromorphone, regardless of which route they're talking about, it was about 5 to 1, 5 of morphine to hydromorphone. Going from hydromorphone to morphine by the same route was 3.7 to 1. But Lawler said, you know, it's a really small study. The data is highly skewed, very highly variable. And they said, you know, we don't think this is clinically significant. So for all intents and purposes, we will assume it's bidirectional. But Dr. Reddy's data certainly has convinced me as well. So what about this 10 to 25 with morphine? Now, I will confess to you, don't tell the others, but if I'm in the car and a nurse or a doctor calls me and says, could you do this calculation? Certainly it's easier to divide by 3 than 2.5 if you're on the fly. So yes, it's somewhere, 10 milligrams of parenteral morphine is somewhere between 20 and 30 milligrams of oral morphine. I can show you data for all 3 of those. There's Calso, what an early researcher said 20 to 30 milligrams was 10 milligrams IV or sub-Q. Sarlander said 10 of parenteral is 20 oral. Takahashi said, yeah, it's between 1 to 2 and 1 to 3. And Lachine said it's 1 to 3. So it's really kind of all over the place. You know, and I think the thing about these charts to remember is it just gets you in the ballpark. It is not set in concrete. So this is why I did the 10 to 25, so the hydromorphone would work out well. So here we have a case of PR, a 58-year-old man with stage 4 end-stage lung cancer, stage 4, admitted directly to the hospice inpatient unit with a complaint of uncontrolled pain. He started on an IV infusion of hydromorphone at 0.2 milligrams an hour, which is titrated up over 4 days to 0.5 an hour with a bolus of 0.2. He's using that bolus about 4 times a day. It's time to discharge the patient home with hospice care, and you would like to switch him to oral morphine. So what would you recommend? So first thing you have to do, I advocate a 5-step process when you're doing an opiate conversion calculation. The first step is thoroughly assess the patient's complaint of pain or reported pain. It's not really a complaint. The second is to add up your total daily dose. So he was getting 0.5 an hour times 24 is 12 milligrams, and on average 4 doses of the 0.2, which is 0.8. So his total daily dose of IV hydromorphone is 12.8. This is the equation I always use when I do a conversion calculation. I put my unknown in the numerator on the left, and everything on the left is real life data. So we're solving for X milligrams of oral morphine over the 12.5 milligrams of IV hydromorphone he's on. Everything on the right comes from the equivalency chart. And you'll see oral morphine is in the numerator on both sides, and IV hydromorphone is in the denominator on both sides. So I set it up, 2 times X equals 25 times 12.8. X comes out to 160. So in my mind's eye, I pop that 160 in the equation where the X is. And I'm looking at 160 over 12.8. Does that make sense? And then I look at the right, 25 over 2. Does that make sense? It does. But when you're switching opioids, because you don't have complete cross tolerance, if the patient's pain is well controlled, you would probably reduce what you calculated by anywhere from 25 to 33%. So I calculated 160, we're gonna go with 120 and put this patient on MS-Contin, the long-acting morphine, 60Q12. So again, Reddy's bottom line is shown here in this chart. So what is the important point from that case? When you're going from one opioid to another, you use the conversion from my chart here and then slightly reduce for lack of cross tolerance. All right, and then again, I think The most important thing to remember, whether you use my chart or your chart or the man in the moon's chart, it doesn't really matter. When you calculate that number, the most important thing is, step 3 is doing the ratio calculation. Step 4 is adjusting that to account for either lack of cross tolerance or the patient's in horrible pain or what they're too sleepy, whatever it may be. And step 5 is the most important one, monitor your patient. But whatever you do, whatever chart you use, the number you get is really just get you into the ballpark. So I don't know which seat is yours or how quickly you're going to get to your seat. All I know is it's in the ballpark. So you have to still use some common sense. This is why I do not like online opioid conversion calculators, because people tend to turn off their darn brain. So please, please still use your clinical judgment. All righty. So there's the 5 steps I just talked about. Assess the pain complaint, determine the total daily dose, decide which you're going to switch to and set up your ratio, do your math, individualize the dose, and then follow the patient. And this is an opioid conversion card that I produced that if you would like me to send you a copy, email me. I need your mailing address. It's laminated. On one side is the opioid conversion calculations, and on the other side is dosing methadone. We published a lovely paper on safe and effective use of methadone in hospice and palliative care. And there are like 5,000 different ways to convert to methadone. What we came up with is if they're on anywhere from 0 to less than 60 milligrams of oral morphine equivalent, we go with opioid naive dosing, which is anywhere from 2 to 5 or even up to 7.5 milligrams a day of oral methadone. Mostly in hospice, we do between 2 and 5. We have a lot of little old people we treat with like 1 milligram Q12. But if there's somebody who's younger and they're really in a lot of pain, we may go as high as 2.5 Q12. Always think about your interacting drugs. I'm most particularly interested in the enzyme inhibitors. And my little tip for that is there's 8 million drug interactions with methadone. But when a nurse or doctor calls me, my first question is, are they on amiodarone, any anti-infective drugs, or antidepressants? Because that's going to be 90% of your business with enzyme inhibition. And if I get a positive, we've got to drill a little deeper to see, is that one of the drugs I have to worry about? But it's antibiotics and antifungals we really have to worry about. Now, what if they're on greater than 60 milligrams a day? If they're between 60 and 199 and they're less than 65 years old, we use a 10-to-1 conversion. If they're on 200 or greater and or over 65, we do a 20-to-1 conversion. If you look at the column on the right-hand side, I think this is important guidance. Do not increase the dose before 5 to 7 days. That's so important. And don't increase the total daily dose by more than 5 milligrams a day in total. But once they're up to 30 a day of methadone, you can increase by 10 milligrams a day. But, I always have to, prescribers love to go from methadone 10Q8 to 20Q8. No, you cannot. That is too big of an increase. It's not that methadone has saturable kinetics like phenytoin, but, it does accumulate. So no, you don't want to do that much of an increase. Often patients come into at least our hospice on these crazy high opioid doses, like IV dilaudid, 20 milligrams an hour IV. It's like, that's insane. And I have to wonder, is their pain worse because they have hyperalgesia? So it's not a linear conversion to methadone. So the most we ever do with a home care patient is going to be 30 milligrams. If it's inpatient, maybe 40 of oral methadone. But we try to hold the line there. And generally, simply taking away the initial opioid is going to be beneficial. And it brings a lot to the table. And again, reduced by about 25–30% if they're on an enzyme inhibitor. And our nurses go out to visit the patient every day for 5 days with a new start on methadone. And then we use our judgment with dose increases. All righty, so moving on. Now we're going to talk about goal concordant prescribing and deprescribing. So before I get to this medication list, what the heck, what's this goal concordant care? We always talk about deprescribing, but it's sort of like, hospice kind of has a bad name with some people. Now palliative care, some people think that's kind of a bummer. And even deprescribing is getting kind of a bad rep, but it's a valuable thing to do. So I think goal concordant prescribing is absolutely appropriate. So let's look at a typical hospice patient. This actually was my friend's grandfather, 94 years old, with end-stage COPD, recently admitted to hospice. He was taking coenzyme Q10 supplement, Preservision, ARIDS, azithromycin, levothyroxine, ramipril, omeprazole, furosemide, famotidine, rosuvastatin, finasteride, amlodipine, warfarin, and duoneb. That is a lot of medication, isn't it? So I mean, looking at that list, are there some medications you think we could probably let go of now? I mean, anything that's a supplement like coenzyme Q10, yeah, I'm not even sure why he's on it. I know he's on a statin, and some people use coenzyme Q for the statin, which raises the question, does he need the statin? And Preservision, that you've never seen that tablet. It's about the size of my shoe. So talk about a choking hazard. Good grief. And then I always wonder, why would somebody be on a PPI and an H2 blocker? Because the PPI does everything the H2 blocker does and more. So that doesn't make any sense. And this guy's on only 5 milligrams of amlodipine. That's sort of like licking the tablet. It's such a low dose. Ramipril 10, that's fairly low too. So I think we've got some wiggle room here. So how do we go about doing deprescribing or coming up with goal concordant prescribing? Well, there are several approaches that we can choose from. We can do a comprehensive medication review, kind of a holistic review, or we can do targeted deprescribing, like looking at certain medication groups. Next, we could identify decision support tools, which I'm going to cover, to inform your deprescribing. These are tools that will help the clinician. And then applying the tools, and most importantly, preparing for the deprescribing conversation. That's really important. It seems like in hospice so many times we've got a patient and maybe an older adult, and one adult child here where I live is taking care of them, and there's another adult child 3,000 miles away who's trying to call the shot. So sometimes it can be a hot mess. Alrighty, so this is one of the first tools that I like to talk about. It's called MedStopper, and I've given you the website there. What evidence informs this application? Well, they use several. They use the Beers criteria, the STOP, the Edmonton Frail Scale, and I really like this other link here, the number needed to treat.com. So THENNT.com. So I think that's really how many people do you have to treat when one gets harmed. So the lower that number, the bigger trouble you're in. So it combines all these criteria, and its limitation, it does not include vitamins and supplements, antibiotics, or combination products. Alrighty, so if you look at, this is the output here. So you put all the medications in the software, and the software then produces this output, which will give you a stopping priority. And I'm going to show you a larger slide on the next slide. But you can see for the first drug, which is levothyroxine, we see a big red unhappy face. So is this going to improve any symptoms for the patient? No. Could it reduce the risk for future illness? Nope, not so much. Could it cause harm? Well, probably not. So you can see they also try to provide some justification for their rationale for the decision making. So I really like that they parse it out into, can this medication improve symptoms the patient may be having, reduce the risk for future illness, or may cause harm. So here's a larger slide showing this exactly. And you are certainly, if you look up here at the top of the slide, you can arrange the medications either by stopping priority or their medical condition. So that's very helpful. I like the stopping priority, like what's the most on fire right here. That's very helpful to me. I try to only stop one thing at a time. I mean, certainly if it's a vitamin C or a multivitamin with iron or whatever, you can probably discontinue that with other medications. But if you have an untoward event, how do you know which medication to blame? So for example, with the levothyroxine, if someone has a short prognosis, like weeks, for example, it's got a very long half-life. So withdrawal is unlikely to be a high priority. So they've got it here actually as the number one if you sort by priority. Warfarin, when you ask some drugs, it may ask you the indication. So here they did ask the indication, and you can see it's for AFib. And they do have the link there for the number needed to treat webpage. And if you click that, it goes to the NNT.com. They also have a suggested taper approach, which I think is pretty awesome. You know, when I lecture to nurses, I say, you know, if you don't know for sure how to taper a drug, anything, or whether you can stop it suddenly, anything that affects your head or your heart, I probably would taper. So indeed, warfarin is probably one that we should certainly target the INR range, but ramipril, for example, I probably would reduce that because it's an antihypertensive. And I like the next column. Look at this. So you have to monitor your patient after you taper down or stop a medication. So what should I look for? What should I look for that would tell me, oh, maybe you shouldn't have done that? So in the case of levothyroxine, it's going to be the return of hypothyroid symptoms such as tiredness, weakness, weight gain, hair loss, constipation, and so forth. So I find this very, very useful. And again, I love the inclusion of the number needed to treat. All right, the next is the Stop Frail. The Stop Frail is screening tool of older persons' prescriptions in frail adults with limited life expectancy. I think this is an awesome tool. This is sort of based on the stop-start criteria. The stop-start are indicated for older adults, just older adults, not necessarily frail or terminally ill. Which medications should you stop? And the other half is these are medications you probably should start. So this is focusing just on frail adults, so people with a life-limiting illness. So it's actually a list of potentially inappropriate prescribing indicators designed to assist physicians and other prescribers with deprescribing decisions. It's intended for older people with limited life expectancy for whom the goal of care is to optimize quality of life and minimize the risk of drug-related morbidity. The goals of care should be clearly defined, and where possible, medication changes should be discussed and agreed upon with the patient or the family. Let me tell you, the family part, that whole discussion there, often that's your stumbling block. So who's an appropriate candidate for using the Stop Frail guidelines? It's patients who meet all of the following criteria. Number one, activities of daily living dependency. So in the ADLs, maybe the IADLs, and or severe chronic illness and or terminal illness. 2, severe irreversible frailty. So in other words, they're at high risk of acute medical complications and clinical deterioration. And 3, the practitioner overseeing care of the patient would not be surprised if the patient died in the next 12 months. So of course, we all know that's the surprise question. Would you be surprised to hear this patient died in the next year? So here is a portion of the Stop Frail. It's actually an entire page, so there is more than past section F. So section A is, I like this. It's kind of a global indicator. So any drug that the patient persistently fails to take or tolerate despite adequate education and consideration of all appropriate formulations. So if somebody's not taking a medication, or they're, some days they take it, some days they don't, maybe we don't even need the medication because obviously they're not suffering from the sequela of taking it so inconsistently. Another big one is a drug where nobody really knows why the heck they're taking it. That's a hot button for me. Often patients can continue medications through clinical inertia. So one prescriber starts the medication, keeps them on it for 20 years, and that prescriber dies or whatever, and the patient is inherited by another practitioner, and they're not even sure why the patient was continued on it, but due to clinical inertia, they keep rolling along. So if you don't know why they're on it, maybe they don't even need it. And then if it's a drug for symptom control, and now the symptom's better, whether it's pain or nausea or whatever, then maybe we don't need that either. And then they go into the different body systems. So cardiology, they look at the lipid-lowering therapy, antihypertensive, anti-angiogenic, and so forth. So I find this a very useful tool. These were derived using a Delphi process. This is not graded evidence. It was based on clinical experience. It's not an app. It's just a one-pager, but I think it's very useful. So something you may want to look up. All right, I did talk about the stop-start criteria. The difference here is this is for older adults, and they approach it in 2 ways. The stop-start is for potentially inappropriate prescribing. It's a screening tool of older people's prescriptions, the stop part, and a screening tool to alert to maybe things you should be starting. So it aims to address potentially inappropriate medications and potential prescribing omissions. So where did they come from? The criteria references, as you can see, section B with the stop criteria, cardiovascular system is an example. Loop diuretics as first-line treatment for hypertension. That's not a great idea. There's lack of outcome data for that indication, and there are safer, more effective alternatives. But start criteria, maybe if someone has heart failure and or documented coronary artery disease, starting an ACE inhibitor might be a grand idea. All right, I'm sure everybody has heard of the American Geriatric Society Beers criteria. The Beers criteria is a list of medications worth discussing with health professionals because they may not be the safest or most appropriate option for older adults. So they're very clear that the Beers criteria are intended for older adults not receiving hospice or palliative care, but they still can be useful in deprescribing conversations. But I will say you have to be careful because sometimes they will make a recommendation that is not consistent with our goals of care in hospice or palliative care. Here's an example. They usually do it by category. They provide an explicit rationale, so benzodiazepines, and you can see they have quite an explanation here of maybe we should rethink the benzodiazepines. They do tell you if it's maybe appropriate in certain disorders. So with the benzos, it seems like, I don't know, some days I think we should just go ahead and put Ativan in public water because everybody and their mother is taking Ativan. But it may be indeed appropriate for seizure disorders, rapid eye movement, sleep behavior disorder, so forth and so on. But generally speaking, they do grade the evidence. They give you a recommendation. So here it's generally speaking to avoid. The quality of the evidence is moderate and the strength of their recommendation is strong. All righty, so how appropriate that you all are sitting in Canada, because the next one is a Canadian website. Deprescribing.org is awesome. They use evidence-based deprescribing guidelines, very, very helpful. So that you can see they talk about different things like proton pump inhibitors, antihyperglycemics, antipsychotics, benzodiazepine receptor agonists, and my personal favorite, the cholinesterase inhibitors and memantine. So these tools are very helpful. They did a comprehensive review. I understand each set of guidelines took a long time to go over, and they provide all the evidence on their website. So they really have hit, I think, some of the most problematic drugs in hospice and palliative care. So what you'll see also on their website, this is pretty snappy, they have these little pocket tools. This example of what their guidelines look like. So for example, this is the proton pump inhibitors. They start off with the green boxes. Why is the patient taking a proton pump inhibitor? If you're not sure, here's what you should go find out. And then if you still don't know, you go to the left there and they give you a recommendation for that. So it gives you the strength. It's very well organized and researched. And again, they worked really hard for these. So I think you could print them out. I will say that my favorite toy in the universe right now is my laminator. So you know what? I would print it out. I would make it front back and I would laminate that bad boy and you are ready to go. All right, the next one is called Lesscron. The approach they took here was less around older adults and more around multi-morbidity and chronic use of medications. And this was an expert consensus panel too. So they have the list of evidence, focuses on deprescribing in the multi-morbidity, and they have 27 criteria organized by anatomical group. Each criterion includes the drug indication for which it's prescribed, the clinical situation that offers an opportunity to deprescribe it, what you should monitor, and the minimum time to follow up the patient after deprescribing. That's what I like with the deprescribing.org too, particularly with the dementia drug. They did a lovely job. The University of Sydney did the work. They've got a whole 100-page addendum on their website talking about how long you should monitor after tapering down and stopping the cholinesterase inhibitors or memantine. And then depending on which symptom crops up and when it cropped up, was that because you stopped the medication or is it disease progression most likely? The thing I like about Lesscron is it tells you the clinical outcome you should monitor. You would think that this is common sense, but not always. And how long should you monitor? So if you are the person recommending deprescribing and you're writing a SOAP note or a consult note, for example, you can put that in your SOAP note. So you can say, these are the things you should monitor, and you should monitor for 2 weeks, 4 weeks, 6 weeks, whatever the appropriate thing is. So here is an example, what it looks like with oral anticoagulants. So you do need to consider, again, the indication for which it's being prescribed. So in this case, they're talking about atrial fibrillation. The deprescribing condition, they're talking about this Pfeiffer questionnaire that's from Australia. Patients also at high risk for falls. Really no health variables to monitor or follow up. Now, if you're looking at the anticholinergics for urinary incontinence, this is another group of drugs that makes me crazy with deprescribing, especially if somebody's catheterized. What are you thinking? So if the patient has a diaper, they call it a nappy there, or worsening of dementia symptoms, if they're getting an anticholinesterase inhibitor, because an anticholinergic is going to block that. So what do you monitor? You monitor their urine control, and they say up to a month, but I think if the patient's going to have a rebound, it would certainly be sooner than a month. So, but you know, I always worry about anticholinergic side effects. Certainly there's a whole body of literature on anticholinergic burden for patients. Alrighty, here is the Garfinkel Good Palliative Geriatric Practice Algorithm. This is wonderful. It's like a critical thinking process. It walks you through a patient's medication list, and you ask yourself a number of questions about a specific medication. So, for example, the first box is an evidence-based consensus exists for using the drug for the indication given in its current dosing rate in this patient's age group and disability level, and the benefit outweighs all possible known adverse effects. If it's yes, rock on, you're great. If it's no, or I don't quite know, then you move on. Then you move on to the indication seems valid and relevant in this patient's age group and disability. If the answer is no, then you should stop it. If the answer is yes, you keep on going. Do the known possible adverse reactions of the drug outweigh possible benefit in old disabled patients? Yes. Well, maybe you should shift drugs. And if it's no, keep on going. Any adverse symptoms or drugs that's related to the drug? No, keep on going. If it's yes, change drugs, and then so forth and so on. So when you go all the way to the bottom, so really your options are, your answers are going to be either stop the medication, shift to a therapeutic alternative, maybe reduce the dose, or continue as it's been prescribed. It's more implicit criteria. These are implicit instead of explicit. But I think it's a wonderful way to teach people a critical thinking process. So as you can see here, being an implicit-based tools, so for example, Beer's criteria or the stop-start would be considered explicit tools. This one's implicit because it's more of a critical thinking process. Applicability to any drug in the clinical context. You don't have to worry about looking up a specific drug. You can see they did cite a study here looking at drugs at baseline using the Garfinkel process. The study group at the baseline had 10.5 drugs prescribed. The control group had 10.97. And then after 6 months, it was a little bit less in the study group, but it had gone up in the control group, and that was statistically significant. So I don't know, is it clinically relevant? I don't know, but I think it's a good critical thinking process. Alrighty, and I just mentioned this, the anticholinergic burden calculator, which I think is a grand thing. Also, there's a sedation calculator. This can be used to work out the anticholinergic burden for your patients, and a score of 3 or more is associated with an increased risk of increased cognitive impairment and mortality. So this can augment your decision making and always looking at the cumulative risk. So as you can see here on the right, we looked at oxybutynin and diphenhydramine. So they both have a strong anticholinergic burden. They each are worth 3 points, so that's a 6 right there. So that buys you certainly at risk for anticholinergic side effects. So what are those? I mean, when you think about the common ones, it's blurred vision, constipation, urinary retention, and dementia or delirium. Absolutely. So it's important to remember these. And this certainly puts the patient at high risk for confusion, falls, and death are the big outcomes that they look at. Then there's one called NSW Tag Deprescribing Tool. This was developed by a translational research project team with deprescribing guidance, and they came out with consumer information leaflets. I know you can't read the print here, but I just wanted to show you they actually did a lovely job on this. So be sure to check out the website that I gave you on the former slide. Step 1, if you look to the left, is should I deprescribe? So basically, this is your patient assessment. And again, this is the one for anticholinergic drugs for urinary incontinence. Should I deprescribe? So they go through a series of questions. Is there a documented indication or symptoms supporting use? Are there adverse effects? Is it likely to cause more harm than benefit? Which is the case with these medications. You are more likely to cause an anticholinergic side effect, maybe it's just dry mouth, but still, than you are to reduce the number of episodes of urination. Does the patient or the caregiver agree with the recommendation? And what I really like about these is if you look at the bottom on the first column, it's sort of like one of those Mad Lib things where they have, blank is currently taking insert name of drug for insert indication and is currently experiencing or at risk of insert adverse effect, and then it really helps you have that conversation. Step 2 is how do I deprescribe? Do I have to wean? Can I stop it cold? Going on for step 2 is what is the alternative management? What can we do non-pharmacologically and pharmacologically? And then what do I monitor? And then they summarize it all on the right-hand side. So it's not available for all drugs in the universe, but I think it's a pretty cool tool, and you might want to check it out. Now, the National Hospice and Palliative Care Organization in the U.S. has a lovely companion resource. They have, for deprescribing, this toolkit. It's freely available on the internet. Decision trees and the flow chart that describe opportunities for deprescribing medications at the end of life. So you can see the ones that are in there, such as antiplatelet, anticoagulant, the dementia drugs, the inhalers. If you look at hospice, and in the U.S., we provide all the medications related to the terminal illness or for a comorbid condition which could worsen the patient's outcome. those can get pretty expensive. And the most expensive home care patient to care for from a medication perspective is somebody with COPD. I mean, some of those inhalers, like the triple ingredient ones, they could be $600 a month. So it's just crazy. And, you have to wonder, can patients use some of these? Like dry powder inhalers, you have to have enough force to suck in to get the medication. And often I think our patients just don't have that. Type 2 diabetes as well. So that's a nice one. Here is an example, again, not for you to see the detail, but they really go through, do a very nice job. So this is antiplatelet and anticoagulant medications, the deprescribing guidance. They tell you which drugs we're talking about here. And then in the middle, why deprescribe? They look at possible reasons why you would think about deprescribing, like the patient's at risk for bleeding. So for example, when we have somebody with atrial fibrillation, my resident last year did a very nice study where we looked at patients with AFib who got a palliative care consult, and we did a CHAD-VAS score and a HAS-BLED score. And actually, it came out that they were equal. So the risk of having a stroke was approximately equal to the risk of a bleed. So boy, I wish there had been a clearer answer, but you're kind of stuck in the middle there. And then they go through how to have the conversation in the bottom of the middle row, patient and caregiver talking points. Again, I think this is so important. I like the SPIKE protocol, SPIKE, which is spikes with an S on the end. It's really a tool developed for nurses to break bad news, but I think it's really beneficial. S is settings, getting to a private room or something. You don't want to do this with 8 million people around. I is information, probing what they already know. P, rather, perception, probing what that person already knows, whether it's the patient or the caregiver. I is information. Can I offer some information? K is knowledge and sharing that information. Like, I know that it reduces the risk of having a stroke, but the median length of stay in hospice for a patient in the US is about 21 days. So even if you have the highest score of risk factors on the CHAD-VAS, if you look at the risk in those 21 days, by averaging it over a year, it's about 12%, and you take that 12% and look at less than a month, it's not very much. So it's actually a pretty relatively low risk. But then you look at the HAS-BLED, or people are falling, and they're at risk for bleeding. So to provide that kind of knowledge. And then when you deliver news like that, like for example, families tend to get very upset when you say, I don't think we need to check grandma's sugar 4 times a day. I know she's got diabetes, but I don't think we really need to go crazy like that. So families often get upset, but the doctor said I had to check grandma's sugar 4 times a day and do sliding scale. Are you using the sliding scale? No. And they get upset when you say, I think we should stop that. People get upset when you want to stop the drugs for dementia. So you have to have the kind, gentle conversation. Tell me how your mom was a year ago. Oh, a year ago, she knew my name. She could walk up the stairs by herself. So she's been on this medication during the last year, and she has continued to decline despite the medication. Is that correct? Yes, that is correct. So that's how you would kind of point out what's going on. So I think we should maybe stop these medications because they actually are, I think, cause more harm than good. I worry about the vagotonic effect of the cholinesterase inhibitors. And this is really the equivalent of breaking bad news. People, because you're taking away the hope by stopping a medication. I mean, you look at Relutek for ALS. In the first 6 months after being diagnosed with ALS, it does reduce mortality at 6 months by about 15%. But then when you look at people who are still taking Relutek 18 months out, they're more likely to die than they are if they were still taking the drug. So sometime between 6 months and 18 months, the tide has turned, and nobody knows why this is. My personal hypothesis is there's about a 20% chance that Relutek can cause muscle weakness. And when you look at ALS, the name of the game is muscle weakness already. So I wonder if the drug-induced muscle weakness or superimposed on the disease-induced muscle weakness was kind of the tipping point. So my point by all this is I really like the patient and caregiver talking points. I think that's very, very helpful. Oh, so the E was empathy. So you seem very upset by me telling you, I think we should stop these medications. And of course they are. So you can empathize. You don't have to agree, but you can be empathetic. And then this was before we had all these fancy tools and all. I've long advocated just a simple critical thinking process. So as easy as 1, 2, 3, ABC. So 1, 2, yes, I did steal that from the Jackson 5. I just reversed it. They have ABC 1, 2, 3. I just flipped it. Number one is, what is the purpose of each medication? I think that's so important. And I always think of the story of years ago. I was in hospice team meeting, and I think the nurse was saying the patient was nauseated or something. And I looked down at the drug list, and the patient was taking digoxin. So I thought, I wonder if the dig is causing it. I wonder what the serum level is. I said, so why is this patient taking digoxin? Can you tell me? And the nurse looked like, oh my God, I can't believe you asked me that in front of this whole team. She was so funny. She kind of lowered her voice a little bit and leaned in, and she said, Lynn, that's a heart pill. I was like, I know it's a heart pill. I'm a pharmacist. I work at a school of pharmacy. Why is this patient getting this heart pill? Oh, I don't know. Great. So if you don't know, could we call the prescriber and find out? Maybe the patient doesn't even need it anymore. It could be causing toxicity. The next question is, how are they taking it? Are they taking it as directed? Like, one of my pet peeves is a beta blocker where the prescriber will write, oh, hold your metoprolol 100 if your systolic is less than 90 or your diastolic is less than 60. So I don't think it's a good idea to be playing peekaboo with a beta blocker. So how are they using it? And then we can all channel Dr. Phil and say, well, how's it working for you? So if the medication is not treating the symptom that it was indicated for, maybe we need to switch or just stop it, for example. So, I mean, just think of all the times we increase and increase and increase the opioid, and it's really not getting the job done. So that's really important. I mean, with opioid therapy, I think everybody should have their own personal line in the sand to say, we need to take a step back and reevaluate the situation. So for me, the oral morphine equivalent of 100 milligrams a day, I say, hold up. Let me step back. Let's do a very careful symptom assessment and see what's cooking. Because if it's opioid responsive pain, most people will respond to less than 100 milligrams. Maybe not. Maybe they do need higher, but I think it's worth a second look. So that's the 1, 2, 3. Then we have the ABC. So adverse effects. Is the patient suffering any adverse effects? And then looking at how's that working for you and the adverse effects, you can weigh in your mind the benefits and burdens of drug therapy. And then again, as I just mentioned, you have the conversation. And I think having those conversations is sort of like the old TV show Columbo. If you're old enough to remember Columbo, it's sort of like he would use motivational interviewing as a technique. So, he walks down the driveway, he's getting in the car, he's got one foot in the car, and then he turns around and says to the suspect, one more question. And you're thinking, hot dog, he's got you now, baby. So motivational interviewing is when you talk to, let's say, somebody with diabetes. So you tell me, Mrs. Jones, that you believe the diabetes medications will lower your blood glucose, and you tell me that you believe lowering your blood glucose will stand you in good stead and hopefully have fewer complications of diabetes. So I'm just curious. So it's, again, no judgment. I'm just curious. If you do believe these medications are beneficial and they'll prevent complications, I'm just curious, why don't you take your medications? So, I always say, ladies, it's like dealing with your husband. If it's their idea, they're more likely to do it. So having those same conversations about deprescribing, I think, is a valuable thing. So back at the ranch with our 94-year-old guy, if we look at these drugs, certainly what I just talked about, the ABC 1, 2, 3, you could use that, or the good prescribing guidelines. And then you can see MedStopper is very beneficial throughout the whole thing. Probably the only one that for sure I would keep is the Duoneb. So again, the coenzyme Q, I would probably stop that because I probably would stop the statin. The Preservision, again, this is for macular degeneration. You have to take it for 7 years to see any impact of this, and it's for more advanced macular degeneration. And in hospitals with an average median stay of 21 days, let it go, let it go. Alrighty, so from this deprescribing portion that we've just talked about, I just want to say again, there are several different deprescribing tools that can support evidence-based deprescribing. Certainly the Beers list and the stop-start criteria represent explicit tools, whereas the Garfinkel Good Palliative Geriatric Practice algorithm and my ABC 1, 2, 3 are more of an implicit critical thinking process. And you can certainly use something like deprescribing.org or NHPCO's Deprescribing Toolkit, which provides several useful resources when it's a specific class or medication that you're thinking about deprescribing. And there's some references about the deprescribing tools. Alrighty, so next I want to talk about some random things that I found interesting. Constipation. I think constipation is one of the axes of evil in the universe. So when you look at the literature, certainly I'm interested in opioid-induced constipation, but so much of the literature comes from irritable bowel syndrome of the constipatory variety, not the diarrhea. So, but regardless, I think for, opioid-induced constipation is just the syndrome of you're constipated from the opioid. And then larger than that is opioid-induced bowel dysfunction, which is all the GI adverse effects, the constipation, the GERD, nausea, vomiting, bloating, and abdominal pain. So when we look at this whole picture, what are the tried and true? So we've got the osmotic agents like polyethylene glycol. I think that's probably one of our workhorse drugs that we use quite a bit. There's magnesium hydroxide, magnesium citrate. I think the magnesium citrate's a little more harsh, so be careful. It might cause a little hypotension there. And you have to worry about the renal function with all that magnesium. And lactulose. Now, if somebody has hepatic impairment and they're encephalopathic and they're constipated, lactulose is going to be a twofer. I do love me a good twofer, but it's really nauseating. But all of these drugs work to draw water into the gut. So next we have the stimulant laxatives such as bisacodyl and senna. They stimulate colonic motility. And don't forget, there have been 5 or 6 studies showing that senna plus docusate does not work as well as plain senna alone. So in our country, we have senna S. So senna S is off the table, just plain senna. And I love that senna comes in so many formulations. You can get it the tablet, you can get a liquid, you can get a tea, you can get a sprinkle, which looks like Jimmy's. If you put it on ice cream, it's a beautiful thing. Then we have things like the detergents, like the docusate, which don't show me a whole lot, and enemas, which a lot of the enemas don't show me a whole lot either. I mean, a Fleets is only, I think, 4 ounces. I mean, if you really have somebody who's like impacted, you might need a 1 liter warm water soap suds enema. Yeah, baby, that's going to work. All right, well, let's say the tried and true don't get the job done. What is next? So what I just described to you are considered first line drugs. Second line drugs are probably going to be the Pamora. So of these 3, probably the one that gets the highest rating is nalmefene. So this is structurally related to naltrexone, and the evidence is a little bit better than naloxegol and methylnaltrexone. So each of them has some sort of a function that keeps it from crossing the blood-brain barrier, and that's why it does not reverse analgesia. So, for example, the naloxegol is a pegylated molecule. It's got a long pegylated tail. Methylnaltrexone is just that. It's got a methyl group on the naltrexone, and now it's a quaternary amine, so it doesn't cross the blood-brain barrier. And then we have selective serotonin agonists such as prucalopride. That's rated a little bit lower than the Pamoras. So now what's third line? So the third line are the secretagogues, and we have several. Lubiprostone, which is Amitiza with 1A. That's a typo. I got excited there. Linaclotide or Linzess, plecanatide or tenapanor. But that's a new one on me. So what is this group here? So these are all going to be third line. And the little blue box there, I have something for you there, which is looking at what are the drugs that they prioritize for inflammatory bowel syndrome with constipation. As I just said, polyethylene glycol, again, they call this the pole therapy. It's the first line of defense. The antispasmodics and the peppermint oil is for the abdominal pain. Tricyclic antidepressants, there's some pretty good data. Rifaximin, which is really expensive, and the SSRIs. All right, so this is a wonderful slide. They offered freely to be able to use from the Journal of Gastroenterology. This looks at the mechanism of action of the secretagogues. So secretagogues act by either increasing the luminal fluid content by acting on chloride channels, which includes linaclotide, plecanatide, or lubiprostone, or the sodium hydrogen exchanger 3, which is a tenapanor. So that's how they work. So what about the efficacy of these? Probably lubiprostone has the best data. So people are recommending that as one of the first lines, and then followed by the rest. Now, I do think price is a consideration. When is it not a consideration? So this is part of the reason also why they're a third line. Again, lubiprostone probably has the most and best data. And the dose there is 24 mics by mouth twice a day. It's about $450 a month in the US. Linaclotide could be anywhere from $600 to $1,200, and plecanatide about $600 also. Tenapanor is about $1,800. And I know methylnaltrexone also is around the $1,500 mark too. So when you look at guidelines for opioid-induced constipation, the American Gastroenterologic Association Institute, as well as an Italian expert consensus group, determined that the secretagogues are third-line therapy or opioid-induced constipation. So it's nice to know where they fall. Sometimes we'll get a patient admitted to hospice on one of these secretagogues, and they're very expensive, and we have to provide it. So I asked, have we tried the garden variety of stuff? I mean, when you're looking at $1,800, I could give everybody on the East Coast of the United States Senna for $1,800. Good grief. So it is important to consider where are you and what have you already tried. All right, I mentioned number needed to treat when I was talking about the de-prescribing tools that we had available. So the number needed to treat is the number of patients who need to be treated to get one patient with more than 50% pain relief, for example. So I think it's useful to look at this once in a while. So if you look at carbamazepine, and notably for trigeminal neuralgia, 1.4, that's amazing. Topiramate, well, topiramate is 7.4, but more importantly, the trade name in the US is Topamax, but the patients all call it Dopamax because it gives them such severe medicine head. If you look at the other ones in the right-hand column, tricyclics, 1.7 to 3.4, and then all the way down to the gabapentinoids around 3.2. And the number needed to harm, if you look at to the right, so you do get more benefit than harm from the TCAs. The SSRIs, 19, but they don't work very well for neuropathic pain. And the SNRIs and bupropion, just a smidge more well tolerated at 21.5. All righty, another thing that makes me crazy is topical products for pain management. Do they work? Well, this guy is saying, no way, Jose. So this was a very nice study looking at compounded topical pain creams to treat localized chronic pain. So this was done in the service, a military treatment facility. They had 399 patients with localized pain, which is classified by their physician as either mostly neuropathic, mostly nociceptive, or mixed. So again, 399 patients, and these are the compounds that they used. So don't get me wrong, pharmacists who can compound, I think they're angels straight from heaven. It is too much like cooking for this girl. You do not want me to cook for you. You do not want me to compound for you. So if it's neuropathic pain, they made something with ketamine, gabapentin, clonidine, and lidocaine. Now this is for topical administration. If it's nociceptive, they went with ketoprofen, baclofen, cyclobenzaprine, and lidocaine. And if they thought it was mixed, they gave them the whole darn kitchen sink. And they had a fourth group that had placebo. So the pain was either their back in the rear end, the neck, a limb, or some other location. So again, the concentration of these ingredients, just for your edification here, ketamine 10%, gabapentin 6%. This is all very voodoo-ish to me as far as I'm concerned. And the instructions were to apply to the affected area 3 times a day. And the amount applied was determined by the size of the area. And the investigator decided there. So they had 4 rotations for a 5 and put it in a 5x5 area. So the primary outcome is the average pain score 1 month after treatment, and a positive categorical response was a reduction in pain by 2 or more points on a 0 to 10, with a satisfaction score of 3 or higher on a 5-point satisfaction scale. The data was collected by phone by a trained blinded investigator not involved in patient care at 1 month and 3 months. So again, 399 started the trial, 390 finished it. Those soldiers, they know how to take good orders. 202 were assigned to a study drug, 197 to placebo. So drum roll, please. No change in pain score at 1 month between the drug and the placebo. So for the neuropathic pain, they saw a 0.1 point reduction in pain. Wow, that's not very much. Nociceptive with 0.3 and the same with mixed. And the quality of life thing did not differ between the two. So I think the bottom line here is if someone has intact skin, it is difficult to treat pain. Now, I know we have the topical lidocaine, like the lidoderm patch, but the pain has to be fairly superficial for it to work. Lidocaine patches have worked well for certainly post-herpetic neuralgia, what it's indicated for, but even for some lumbar pain, it's been shown to be effective. And in the US, it's on for 12 hours, off for 12. But there's actually good data saying you can leave that patch on for 24 hours and then take it off and replace it right away with another one. Of course, that's assuming good liver function, since lidocaine is metabolized by the liver. I will say the one compound that especially makes me insane in hospice and palliative care is ABHR gel, which is Ativan, Haldol, Reglan, and Benadryl for nausea. Why would you do this? What other symptom do we treat with 4 drugs right out of the gate? But a lot of hospice nurses swear by ABHR gel, and you rub it on the inner aspect of the wrist. But there have been several good studies looking at this. So the first study looked at the serum level of any of those 4 drugs after achieving steady state and chronic application of this product. And only Benadryl could they even detect with the most sensitive HPLA assay, and it was highly erratic and severely subtherapeutic. So none of the other 3, they couldn't even find them on an assay. Then the next study looked at using this ABHR cream in patients with cancer who had nausea. And again, they couldn't tell the difference with or without it. But hospice nurses swear by this. And I actually, right when that second study came out, I was asked to review a paper, and they did acknowledge the paper where they said it did not have an effect in patients with cancer and had nausea, but they hypothesized that, you touch your face about 15 times an hour. So maybe, as you're touching your face after rubbing it into your wrist, it kind of wafted by your nose, and it was more the aromatherapy that was fixing it, or maybe just the touch of rubbing it on your wrist. So please don't do that. Please don't use those for multiple reasons. Now, I am very, very, very fond of intensols. What's an intensol? Let's look at this case. Here we have Mr. Jones, a 58-year-old man with lung cancer who was admitted to the inpatient hospice unit for pain out of control. His pain was eventually controlled on an IV PCA infusion of morphine, 2 milligrams an hour with a 1 milligram bolus every 15 minutes as needed. He is very weak and has a hard time swallowing, but he wants to go home. Do we have to send him home on the IV morphine? So he's getting 54 milligrams a day of the IV morphine, which is about 162 oral morphine, which would be about, it's under 200 milligrams, and he's under 65 years old. That would be about 16 milligrams of oral methadone. So I loved using methadone. So what do we use for breakthrough? I try hard not to use methadone for breakthrough. So the way you dose breakthrough is you look at the total daily dose of their scheduled opioid, and you give 10 to 15% of that on average, and offer it every 2 or 3 or 4 hours. So 10% of 162 is going to be 16, 15% is going to be 24. So we could probably do 20 milligrams, for example. So because he has a hard time swallowing, the Intensol is a high concentrate oral solution. You can put up to 1 ml in the buccal cavity. Even if someone's unconscious, you can prop their upper body up about 30 degrees and they won't aspirate it. So here we have methadone 10 milligram per mil. So you could give him 8 milligrams Q12, so it's 0.8 mLs in the buccal cavity. And we have a morphine 20-to-1 oral solution. That's, I think the trade name of Intensol is not even really used anymore, but we still call it that. So this would be 1 ml of morphine. So the only time I think we have trouble using an Intensol is if the patient has a lot of oral secretions. Like sometimes ALS patients, we can't do that. And we have several available in our country. We have alprazolam, dexamethasone, diazepam, lorazepam, methadone and morphine, as I mentioned, oxycodone, which is crazy expensive here, and prednisone. So again, prop the upper body up 30 degrees, and you can put up to 1 or 1.5 mLs in the buccal cavity. If you need to give 2 mLs, you can put 1 ml in both sides. Now, does the drug actually get absorbed from the transmucosal space? It depends. So if you look at this graph that I have here, of the first drug is morphine. Morphine is the most water soluble of all the opioids. So as you can see, it's not even quite 20% transmucosally absorbed. But studies have shown, particularly with methadone, which is a little bit higher, it's probably closer to about 25, 28% absorbed. You don't have to change the dose, because even though only about 20, 25% gets absorbed from the oral cavity, it's sort of, the solution sits there sort of like a depot effect, and then slowly, slowly trickles down the throat, and it's absorbed from the GI tract just as if the patient had swallowed it. Oxycodone is even a little bit lower. Then we have levorphanol, hydromorphone, so forth and so on. Methadone's a little higher because it's a more fat-soluble drug. And then fentanyl and buprenorphine are highly lipophilic drugs. So you can see fentanyl, of course, we have all those transmucosal products on the market. So the first one was Actique, which is the fentanyl citrate lozenge on a stick. And then now we have a generic, of course, but then they took it off the stick and added some effervescence, and we had Fentora. There was a transmucosal film called Onsalis, which I think is gone now. There's Subsys spray under the tongue. We had a sublingual tablet named Abstral, but I think that's off the market now. And we also have Lazonda, which is an intranasal spray of fentanyl. But as you can see, the bioavailability when administered that way is about 50%. But interestingly, you cannot do equianalgesic conversions between these transmucosal fentanyls, nor can you convert from oral morphine to a transmucosal fentanyl. You have to start at the lowest dose. Alrighty, I think this is such an amazing magic bullet. The use of pregabalin in the management of chronic uremic pruritus. So this was a nice study looking at chronic kidney disease patients with severe intractable itching. It was a small study, only 12 patients. And because, of course, pregabalin is renally excreted, they had to dose adjust. So they gave them only 25 milligrams a day. So they looked at their pain rating from the itching. And at baseline, on a 0 to 10, it was 9.7. So this is where they want to get out the wire hairbrush and scratch their skin straight off. After 1 week, it was down to 3.7. After 4 weeks, it was down to 3.2 and down to 3 at 24 weeks. So that's really impressive data, I think. I think this is a good one too. So, talking about not stopping medication suddenly, as we discussed with the deprescribing. The Institute for Safe Medication Practices reports on drug withdrawal symptoms. And they talk about, which drugs are more likely to cause a withdrawal symptom. So this is the chart that they came up with. So any drug that affects serotonin, so this is going to be your SSRIs, certainly your SNRIs, any drugs that affect GABA, so pregabalin, Viagra, and gabapentin, and effects on opioids, so any opioid, dopaminergic drugs, and then other mechanisms such as baclofen, cetirizine, and aconitide. So these should be tapered down, and I would access one of those deprescribing resources I shared with you to get better guidance. I do think hospice nurses it's kind of like their spidey sense, I would say. They're very good at saying, you will not be able to swallow tablets or capsules in 6 days, 12 hours, and 14 minutes. So they're really good at saying, I think we should start tapering this drug down because I don't want to come in one day and all of a sudden you can't swallow your antidepressant. That would not be a good look. All righty, this is pretty useful data too. I think this has changed the face of treating nausea in advanced illness. Looking at olanzapine, they had a study looking at 30 patients, 16 women, 14 men, aged 39 to 79, an average of 63. And they were complaining of nausea that was unrelated to chemo. They all had advanced cancer. The chronic nausea had been present for at least a week with a severity of 3 or higher on a 0 to 10 scale. So they gave them olanzapine, 5 milligrams or placebo in the evening by mouth once a day for 7 days. The patient-reported outcomes used for this study, they looked at baseline and then daily for 7 days, with the primary outcome being a change in nausea numeric rating. The baseline median nausea scores on a 0 to 10 were 9 out of 10. The placebo after 1 week and 1 day were still 9 out of 10. The olanzapine on day 1, it was a 2 out of 10, and after a week, it was 1 out of 10. That's pretty amazing. So we have long known that anti-dopaminergic drugs are very effective in treating nausea. We do like to use haloperidol, although olanzapine now is generic in our country, so it's very inexpensive. But these patients had less emesis, less use of antiemetic drugs, better appetite, less sedation, fatigue, and overall better well-being. So we use this all the time. And then I have some sad news here about our friend mirtazapine. This is a study looking at mirtazapine and cancer-associated anorexia and cachexia. I mean, it's pretty titillating to think about all the things mirtazapine could treat. So insomnia, anorexia, neuropathic pain, and depression. Oh my goodness, it's a four-fer. Does it really treat all 4? So this study looked at 120 cancer patients with anorexia who had an appetite loss of at least 4 or higher on a 0 to 10 scale, and cachexia, as defined by greater than 5% body weight loss over 6 months or 2% plus the BMI over 20, and depression scores. They randomized them 1-to-1 to either get mirtazapine 15 at bedtime or placebo for 8 weeks. And the primary endpoint was change in appetite from baseline to day 28. They also looked at a whole bunch of other things like quality of life, fatigue, depression symptoms, so forth and so on. So we did see that mirtazapine was associated with significantly less increase in depressive symptoms, but a higher prevalence of somnolence. So you can use it to treat depression, you can use it to treat insomnia. But bad news, no difference in the appetite score or any of the other outcome markers. So if you're thinking mirtazapine is really going to increase appetite, think again, because it really does not. Personally, you don't have to talk hard to convince me to recommend a corticosteroid. I do love some dexamethasone. I think that probably does a better job. Or we could really go crazy and go with a cannabis-based product. Alrighty, these are slides from the talk that I prepared for 2 days ago, but I thought I had 90 minutes, but really it was 45. So I thought I would throw them in here since I have a few minutes left. And it's talking about, it's a difficult topic to wrestle with, deprescribing anticoagulation. I don't actually like giving this part of the talk because there are no clear-cut answers. So why do we anticoagulate hospice patients? Well, probably the two biggest reasons are venous thromboembolism and atrial fibrillation, but it also could be acute coronary syndrome or percutaneous coronary intervention, just general atherosclerotic cardiovascular disease, or if they have valvular heart disease. So we all know what the sequelae are of these indications if we do not anticoagulate the patient. So what are these anticoagulants and antiplatelets of which we speak? So as you can see, we have a lot of them. We've got the vitamin K antagonist warfarin. We have the DOACs, direct-acting oral anticoagulant. We have the direct thrombin inhibitor, dabigatran, and the factor 10A inhibitors, apixaban, edoxaban, rivaroxaban. We've got the others, such as standard heparin and low molecular weight heparin, and the antiplatelets, notably aspirin, the P2Y12 inhibitors, and other medications. As you can see, if you look at like cilostazol, that's really for peripheral vascular disease. So we have lots to pick from here. So how common is antithrombotic use at the end of life? The antithrombotics are frequently prescribed for patients with limited life expectancy. This was a chart review of 180 patients who died of malignant or non-malignant disease in the Netherlands. And they were either at home in the hospice or the hospital. They reviewed their last 3 months of life. And 108 out of 180, 60%, at some point had used antithrombotics in the last 3 months of life. Wow. 33% of these patients died at home, 21% in hospice, 45% in the hospital. And then there were 157 prescriptions for antithrombotics among these 108 patients. 30 were warfarin, 60 were heparin, and 66 were platelet aggregation inhibitors. I think there's one unaccounted for. And of the 51 patients using heparin, 32 only received a prophylactic dose. And a little over 75% of the patients, they continued the antithrombotic until the last week before death. So they're pretty darn common. So, I think the big thing, let's talk about venous thromboembolism and atrial fibrillation. So VTE, we're talking about DVT and PE, which occurs in about 1 in 1,000 patients in the average population. We know that the risk increases with age, with reduced mobility, and concurrent chronic illness, including cancer. The treatment approach has changed from this nihilistic point of view, which is a big PE, it's not a bad way to go. Boom, you're done. No, it's not boom, you go. We know that it's only an asymptomatic event in about 10% of patients. The other 90%, the majority, suffer a prolonged symptomatic death averaging 2 hours. That's got to be a horrible way to die, with severe dyspnea, tachycardia, and very distressed. I do think that DVT and PE are underdiagnosed in hospice and palliative care. So for example, PE, what do you see as a symptom? Dyspnea, anemia, pulmonary edema, infection, pleural effusion. We have that all the time in hospice patients. So who knows if it's their heart failure or if it's a PE. A DVT, swollen legs, likely related to hypoalbuminemia, left ventricular failure, and so forth. We see that all the time in advanced illness also. So I think we actually underdiagnose them. So the treatment for cancer-associated thrombosis is low molecular weight heparin. It has been shown to be superior to warfarin in preventing recurrent VTE without an increase in bleeding complications, has fewer drug-drug interactions than warfarin, that's for sure, and rarely requires monitoring. That's the worst part of warfarin, is sticking a patient to measure the INR. Trials have, however, excluded patients with less than a 3-month prognosis, people with a poor performance status, increased bleeding risk, renal impairment, low body weight, thrombocytopenia, and so forth. It does require daily 1 or 2 injections. It may reduce quality of life and may be less acceptable than the oral equivalent. Although interestingly, when you look at the studies comparing which did you prefer, the low molecular weight heparin or warfarin, people prefer the low molecular weight heparin. Maybe it's because they don't like getting that INR drawn. So guidelines recommend indefinite anticoagulation for patients with ongoing cancer, but none really address what do we do at the end of life. This was a recent study of almost 1,200 patients admitted to 22 hospices or palliative care units. 90% were cancer, a low incidence of VTE, but a high incidence of clinically relevant bleeding. The analysis showed the bleeding was associated with thromboprophylaxis, and they concluded in that population, the bleeding may outweigh the benefits of treating in that population. Then there was the hospice inpatient deep vein thrombosis detection study, which is a prospective longitudinal observational study looking at 300. This study cracks me up. It just kills me. I don't know how the heck they got it through the IRB. I have a heck of a time with IRB, and I don't do anything this crazy. They looked at 343 cancer patients who underwent bilateral femoral vein ultrasonography on admission and weekly until death or discharge. How they got that through, I don't know. The patients had an average Australian Karnofsky performance scale of 49 and survival of 44 days. Femoral DVT was observed in 28% of participants with minimal symptoms, and there was no difference in survival with or without the DVT. So it really is kind of confusing, isn't it? So this is a tough one. There is no clear clinical guidance. There is limited outcome data. I don't mean to wimp out, but I really think it boils down to a case-by-case decision. I think this is where your goal concordant prescribing comes into place. I think we need to do shared decision-making. How symptomatic is the patient? What's their overall prognosis? How burdensome will the monitoring be? If it's a DVT, is it proximal or distal, upper or lower? Any risk factors or reversible causes we can address? If the patient's very close to death, that's something to consider. And do they take the medication? And what's their history of the INR if they're taking warfarin? If they've been subtherapeutic for 3 months and now they're in your hospice and they've got a couple of weeks left, I think it's okay to stop the warfarin. Okay, so what about our friend atrial fibrillation? Well, this is where you would want to do like my resident did, the CHAD-VAS score. So this is the CHAD-VAS where it's a point system. And as you can see, for heart failure, you get a point, hypertension, a point. The age is either 1 or 2 points. Diabetes, a previous stroke, TIA or TE, vascular disease, and females get a point too. So then you add up all the points. And if you look at the chart on the right, you see the absolute risk per year. So if you don't have any points, that's 0.2 risk. All the way up to 9, it's 12% risk of having a stroke in the year. So I'm not even sure this is mathematically permissible, what I did on this slide, but I did it anyway because I'm a rebel. What can I say? I looked at the very first column on the left and the second column are right from the slide I just showed you, looking at the points and what is the absolute risk per year. So then I took that risk and said, if we spread this, say, 7.2% risk over 365 days, and then we look at, the second column is what happens to that risk if they're anticoagulated. It cuts it by 2/3. So you can see the 7.2 goes down to 2.38. The 12 goes down to 4. Now, if you look at the yellow, this is looking at the mean hospice length of stay, which is 92 days. So if we take that 7% for a year, what is the risk of having a stroke in those 3 months? What's 1.8? If we anticoagulate them, it's 0.6%. The green to the far right is the median length of stay in the U.S. hospice. So as you can see, even if somebody has 9 points, the risk in that 19 days is 0.61%. So it's a little more than 0.5%. Now we could reduce that by 2/3 by anticoagulating them, but I don't know. I do often, Clint Eastwood and I think alike. Do you feel lucky? Do you feel lucky? And this is the HAS-BLED scale. This is looking at the point system for the risk of bleeding, hypertension, abnormal renal function, liver function, bleeding, INR, and so forth. So if you look at adding up the HAS-BLED score, 0 to more than 5, if it's 0, it's relatively low risk. If it's a 0 or a 1, they say, yeah, or even a 2, you should consider doing anticoagulation. But if the score is 3 or higher, the guidance is alternatives to anticoagulation should be considered. Now, this scoring system has come under fire and people have criticized it, but it's the best we have for now. So let's consider a case here. Here we have Mr. Jones, which is a 76-year-old man admitted to hospice with a diagnosis of advanced Alzheimer's disease. He lives in an assisted living facility, although his medical needs are becoming more complicated and he may need to be transferred to a long-term care facility. He has comorbidities of hypertension, his blood pressure is 140/150 over 90/95, diabetes and VAF, and a stroke 3 years ago. He's on metoprolol, metformin, glipizide, warfarin, clopidogrel, and aspirin. So let's look at his risk stratification. If you look at his risk factors, his points come up to 6, which he's got almost a 10% chance of having a stroke in the next year. But then we add up his bleeding risk, and as you can see, it totals 1, 2, 3, 4. So if you look at 4, the guidelines say, maybe you should think about something other than the plan you have cooking right now. So for Mr. Jones, the annual risk of having a stroke is a little less than 10%. So if we look at that median length of stay, the risk is about 0.5%. The annual risk of bleeding is a little less than the likelihood of him having a stroke, 8.9%. And if you looked at 18 days versus 365, it would be a little bit less than 0.5%. So in this case, I would consider an alternative such as stopping the antiplatelets and so forth, and the attending physician agrees to stop the warfarin in this case. So I think I love this slide. I love this slide. It talks about shared decision making. So when it's decision time, you look at all the data, you look at the endpoints, you have to consider the benefits and burdens or risk and reward. You have to look at the impact. What is the relative value of the risk and the reward? I liked on the bottom right there, it's got, oh, don't forget luck. And whose perspective are you looking at it from? And the big question is, what's going to be your output, as you see there on the left? So I think this describes it perfectly. Now, this slide right here is worth the price of admission. This is from an article titled Use of Antithrombotics at the End of Life, an in-depth chart review study. It was published in BMC Palliative Care. It's an open access journal, and they put a Creative Commons license on this diagram, so you are welcome to take it and use it. I love this diagram. So you start at the top left, you have a patient with a life-limiting condition, meaning a life expectancy less than 3 months. And then they have all these little additional data considerations. Like below that, it says, reevaluate if there's a change in clinical condition, if you're transferring the patient, and so forth. But let's assume we're going to go to the right, and then you ask, have they had active or recent troubling bleeding? If the answer is yes, either stop the anticoagulant or, for God's sake, don't start it. If the answer is no, then you go to the next decision point. Death is expected within days. If the answer is yes, stop it or don't start it. If the answer is no, okay, medication being used. Is it a platelet aggregation inhibitor you're talking about, or is it an anticoagulant? If you go left, platelet aggregation inhibitor, they say, okay, what's it for? Is it for primary prevention or low risk secondary prevention, or is it for high risk secondary prevention? So that makes a difference. And they've got, again, either don't stop or don't start for the low risk, and for high risk, maybe continue, but taking into account the patient preferences. Back to the medication being used, if you go to the right, what's the anticoagulant? You want an anticoagulant, you have to think about the thromboembolic risk. Is it low, moderate, which is less than 10%? And they give you those clinical situations there. They say, you know what, don't use it. Stop it or don't start it. But if you go to the right, because it was a high risk, and they list those indications for you there, then you have to look at the bleeding risk. Was it low? Was it high? Should you continue or stop, start? And then, of course, when we look at combination therapy, no evidence of benefit over monotherapy. So I think this diagram is the cat's meow, and I urge you to pull this article and take a closer look. And they have one more diagram, which is shown here, which says patient with a life-limiting condition, discuss the medical advice regarding antithrombotics, inform and discuss patient preference. So all these discussion points, talking about the pros and cons and using the shared decision-making, which makes so much sense to me. So with that, I have completed my formal remarks, and I would be happy to take any questions if there are any, if you're all still awake and breathing.
Wow, I'm surprised you're able to fit all of this in this amount of time. I'm very surprised, but happily surprised. So we have a few questions. We have 6 minutes for questions. So if you have a question, you can always put it in the app. So the first question is, will the slide be available? So so I will try to put it to be able to put it, but I'm not sure exactly how it will be. Again, the session was also taped, so this is something that we are looking to put on the MIPCC. So this is also something that was difficult because we wanted a lot of people ask me for, can I go to psychedelic and pharmacotherapy at the same time? Unfortunately, we cannot split ourselves. So, but I'm very glad of this turnout. So now the first question for you, Dr. McPherson. So could you comment on the efficacy and risk of using small dose methadone with morphine or other commonly used opioid?
That's a great question. Often when we have a patient who is fairly close to death, and by that I mean they will probably be gone before they would get to steady state with methadone, which would be 4 or 5 days. And we commonly use that exact approach that you just mentioned. So instead of doing a complete rotation to methadone, we'll leave them on their current regimen and just throw a little methadone on top of the whole hot mess. Sometimes like 2.5 Q12, maybe 5 Q12, and it's a beautiful thing. I mean, I know the mechanism of NMDA receptor antagonism has been called into question. Maybe it's really a higher dose phenomenon, and maybe the inhibition of serotonin is playing a bigger role than we thought. But I think it does work quite well. And I'm sure you've seen the 2 studies by Shelley Salpeter looking at very low dose methadone with morphine with very, very good effect. And also, before I forget, my email's on the slides, and if you really want a PDF copy, I'm happy to send it to you.
Thank you. Another comment about, or another question about methadone. So you've talked about the going from different opioids such as hydrocodone or morphine to methadone. But what about the other side? So.
Yeah, that's a tricky one. There's only one study that looked at that by Walker, and it ended up being taking the methadone dose and multiplying by 4.7 ended up being the morphine dose. But I personally recommend multiply by 3, because if you're going to immediately go to morphine, I still have to worry about the methadone leaving the body over the next 3, 4, 5 days. So I think I multiply by 3, and I'm generous with breakthrough. And then over the next few days, you're going to have to do some seat of the pants dosing as the methadone dissipates.
Thank you. And what about, do you have any evidence for olanzapine with non-cancer nausea?
I've not seen any studies on that. I think nausea is even more complicated than pain. But just as we do a very careful assessment of pain to determine the pathogenesis of the pain, I think the same thing is true with nausea. I think there's that famous, the 13 M's of emesis. So there's so many causes. I think the antidopaminergic work best when it is nausea that is hitting the chemoreceptor trigger zone, which certainly accounts for opioid-induced nausea. So I think it depends on the mechanism of action of the nausea.
Thank you. And what about VTE prophylaxis for a patient with either palliative care admitted to acute hospital care or hospice?
Again, I don't want to wimp out, but I think that's a case-by-case decision too. How big is the risk? What is the risk for toxicity? What's their prognosis? I think you have to consider all that.
Thank you. And patient so there's a clinical case here. So patient was started on levetiracetam for seizure, past medical history of glioblastoma multiforme, WHO stage 4. Unfortunately, after 1 week of taking this family complaint of behavior change, dizziness, etc. The medication was changed to Vimpat, which is lacosamide. So what other options if lacosamide failed?
Oh my goodness. I don't know. I hate seizures because they're really hard. I think you said levetiracetam was the first drug they tried. Levetiracetam is an awesome drug because it's a pretty clean drug. Doesn't have a lot of drug interactions or side effects. Vimpat, you're going to have to sell everybody's left lung to pay for it. It's hugely expensive, at least here. And I think that also depends on the patient's prognosis. If somebody's very close to the end, we probably would default to around-the-clock benzodiazepine dosing.
Okay, thank you. And what about DOAC or NOAC for VTE or P prevention?
Again, if it's prevention, is it proximal? Is it distal? What's their prognosis? If they're at very high risk, sure, maybe doing that. But if you're worried, I did hear recently that from a cardiology PharmD, that when you're worried about bleeding risk for somebody who falls, you have to fall like 200 times to actually see a major bleed or really wrap your head pretty hard. So, but still, I do worry about people falling. So get rid of the scatter rugs and the little dogs. But I think, again, you're going to have to consider, and I think cost is a consideration too. It could be $300 a month too. I think there's a lot that goes into that decision, and we can't make a blanket call on that.
Mm-hmm. So you presented NNT and NNH about the tricyclic and gabapentinoid. I guess it's for general population. Do you have any more data or more insights through a frail elderly?
No, but I think where we would see the impact of that is not the number needed to treat. I think it might be influencing the number needed to harm because they have so many comorbid conditions that could increase the risk of toxicity.
Thank you. And the last one is please repeat email.
I'll put it in the chat, but my email is mmcphers@rx.umaryland. all spelled out, .edu. So it's MMCPHERS at rx.umaryland.edu.
Oh, I lied. The last one is félicitations or congratulations. Thank you very much. Thank you very much, everybody, for attending this.
Thank you.
And thank you, Dr. McPherson. So it was fantastic. So thank you very much for being here. So you have a last 30-minute break before the last plenary. Thank you, everyone.
Thanks again. Bye-bye.